Hi class, this is Nicole and I'm going to be doing a audio supported PowerPoint for chapter 6, mental status. As you go through this lecture, it would be beneficial if you've printed out these slides, take note, and also have your book open to kind of help you explain some of this, and I might just point out some page numbers to help the lecture. Okay, so chapter 6, it starts on page 73 in your book. So first, what is mental status? Kind of what are we talking about? So it's the cognitive and emotional functioning. And as listed here, there's a definition for mental health. Cognitive, remember, is like our thinking, our knowledge, our problem-solving skills, and then our emotional functioning is kind of our feelings, mood, behaviors, and stability. So there's a lot of things that could affect one's mental status. I've listed out a bunch, and I'm sure you could probably know of someone or can relate to some of these that may affect your mental status. At the bottom there, I've listed other body systems. So for that, some of the examples I have would be like for some of our military people coming back, if they have like a post-traumatic stress, head injuries, brain tumors can affect your mental health, substance abuse, drug use, even like diabetes. Has anyone gotten like a low blood sugar? Got a little, what do they call it, hangry? But that too can affect your mental health. So think of both the physical and the psychological part when it comes to mental health. So, subjective. Obviously, if you start looking on page 74 and 75 in those blue boxes, it will go over a bunch of subjective questions. Even just asking things like, can you tell me your name, your phone number, what's your date of birth, are you married? Those just kind of getting some background information. It'll actually kind of help you when you do your objective and you do like level of consciousness. You ask the similar questions. You can ask about previous mental health problems or any type of counseling they've received. Obviously what brings them in, so you can use cold spa. And in mental health or mental status, it gets a little bit different. So if you look on your case study on page 77, she comes in and she is saying that she's nervous, she's afraid she's losing her mind, and they use cold spa. But some of the questions is just a little bit different. It's not like pain, where you can say, location, where does it hurt? We can't ask like, can you point to where you're nervous? But you could ask like, where does it occur? Like, are you nervous at home? Are you nervous at work? And those type of things. So just kind of read through that little case study with the cold spa and see if you understand it. Personal health history. So obviously their past medical history, any treatment for mental health problems, any type of head injury, meningitis, headaches, anything like that. Family history. There are some psychiatric disorders that have a genetic link, so you'd want to ask about that. Lifestyle. So again, what's their typical day like? Eating habits, sleeping, exercise, things like that. Also ask about their diet, any drugs, prescription or over-the-counter that they take. You could also ask about their support systems, things like that. So those all would fall under subjective. Alright, so then we kind of get into our assessment. So that starts on page 83, kind of 84. So for objective, so obviously you're going to start with the level of consciousness. That's also abbreviated as LOC. And for that, you would typically ask them their name, their date of birth, ask them to tell you where they are, and ask them like the year or the date. So I usually say, hey, can you tell me what today's date is? And if they tell you, yeah, it's Monday, I'll be like, okay, can you tell me the year? Can you tell me what season we're in? Is it spring, summer, fall? Just to get a better idea, because sometimes in the hospital setting, we'll have the calendars like up on the board and we'll put that it's Monday, but I usually try to ask at least the year and then like maybe a season. Then I tend to ask another, like, who's your significant other, who is the president. If there's other people in the room, I ask the patient to name the people just to kind of see, do they really, like, what is their orientation status. Then posture and gait. So again, just how are they sitting? Are they making eye contact? Are they slumped over in a chair? I look at their body movements while I'm assessing and interacting with them. Hygiene and grooming is pretty self-explanatory. I watch how they're looking at me, and then their speech. You can kind of get a general sense of one's mood and feelings. How are they behaving? Are they fidgeting in the chair? Are they twisting their hands? Are they pulling at their hair? Are they rocking back and forth? And then that memory, judgment, and concentration I get as I communicate and talk to them. So the reason I have this picture up on the slides is just looking at that patient, what could you assess? So you could say that she looks kind of withdrawn, a little unkept, hair looks a little messy, she's got like this flat affect, she's kind of staring off into space. It looks like she's slumped in a corner with like a blanket wrapped around her. So again, you can get a lot of information by just observing and looking. And if you go through your book on page like 84 or 85, it will tell you the normal findings and the abnormal findings. So again, when you're looking at one's sorry, when you're looking at one's facial expression, so again, normal would be that they maintained eye contact, they smile appropriately. The abnormal would be reduced eye contact, extreme facial expressions, and then also you'll just kind of look at their medical history. So if they have Parkinson's, they might have more of that mask-like. If they've had a stroke or Bell's palsy, they might have a drooping on one side of the face, and that goes into same with speech. So if you kind of go through your book, you'll see different examples. So level of consciousnness, looking back at that, our LOC. Typically when I'm in class talking to you guys, you're alert and awake. Some of you guys are a little lethargic, but you should be able to define these terms, and they're on page 96 to 97. So again, lethargic, they open their eyes, they answer questions, but they fall back asleep. Obtundant, they open their eyes to a loud voice, respond slowly with confusion, and they seem unaware. Stupor would be that you have to vigorously shake them or do a painful stimuli to get them to open up their eyes, but then they return back to sleep as soon as you stop the stimuli. And then coma would be that they remain unresponsive to all stimuli and the eyes stay closed. So you'll need to know those different terminology and those different stages of LOC. Also, if you look back on page 84, so you have decerebrate and decorticate, and those are two types of posturing that fall under level of consciousness. Both of these are abnormals when you're assessing the level of consciousness. Neither one of these is something you want to see. But decerebrate is where they are going to have an extension of their posturing. So those would be where their arms are extended. Their hands tend to pronate out. Their legs are flexed. You can kind of tell by the picture. Sometimes you'll see their head kind of arch. So again, their shoulders are kind of adducted, their elbows are extended, their forearms pronate, their hands are flexed, and then their feet, they have like a plantar flex. Okay. The next one is decorticate. And how I remember what the positioning is for this is that in decorticate you have the word core, so everything comes into the core. So their arms are flexed in, usually to their chest, their hands are flexed in, their hips are, their thighs and knees are rotated in to the core, so everything goes to the core of the body. I've listed here the decerebrate is the lesions in the dicephalon, midbrain, and pons, and then decorticate is the lesion of the corticospinal tract. Both of these are bad. The decerebrate is the worser of the two. Okay, so decerebrate would be the one I would definitely not want to see. Alright, so there's a ton of screening tools out there, and some of them are listed in your book. I don't expect you to know them all, except for the slums and the Glasgow Coma Scale. The reasons I've put the other ones up there is that I just want you to know that the tools are out there. So if you're working in the ER and someone comes in and they are depressed, you don't have to try to think of the questions to ask them. There's a depression questionnaire. If someone comes in and they are a chronic alcoholic, you know, there's a screening tool out there based on, you know, alcohol use. If someone's confused, you can use the confusion assessment. You can use the mini mental. So again, those are just there for your own knowledge, and know that they're out there. However, you will need to know the slums and the Glasgow Coma Scale. SLUMS is the St. Louis University mental status. It helps with orientation, recall, comprehension, reading, writing, and drawing. And we're actually in class going to do a slums and a mini mental on each other. And then we're also going to do an activity for the Glasgow Coma Scale in class. So in class we will have different patients. I will give you little scenarios and you will have to score them. So for the Glasgow Coma Scale, there's 3 behaviors we're assessing. We're assessing eye-opening, verbal, and motor. So eye-opening response, verbal response, and motor response. The highest you can have is 15 for a score. The lowest is a 3. There is no 0. So technically a dead person could be scored a 3. You can only pick 1 score for each category. So if someone opens their eyes to speech and pain, you can't give them a 3 and a 2. You always go with the highest. So if they open their eyes to speech and pain, you would go with the highest. That would be speech, and that would be a 3. So always give them the best. That's how the scale works. And like I said, I'll go over that in class next week. Alright, briefly talking about Alzheimer's, there is a little box in your book. It's on page 89, box 6.3. These are just some warning signs of Alzheimer's. I'm sure we have all met someone with Alzheimer's. Again, for the purpose of this class and for the exam, please go with the basic warning signs. Please don't go off of what your particular loved one or family member had. But typically, we'll see that they ask the same question over, they repeat stories, they forget their usual activities, inability to manage their bills, they get lost in familiar surroundings. So again, like if they live in an apartment complex and they couldn't find, you know, where the dining hall was, or if they typically went to this same grocery store for the past 30 years and now they're getting lost. You might see that they have a neglect for caring for themselves, and that they rely on others to make decisions. So those are just some of the warning signs. Alright, this is on page 90. It's the difference between dementia and delirium. So for dementia, I'm going to kind of stick to the Alzheimer dementias versus delirium. So on page 90, it breaks it down even further. I just pulled some of the highlights as far as like onset, reversible, irreversible, their speech, orientation, and personality, and ADL. So you can go ahead and look at that. Okay, so that is where the lecture will end. Again, in class, we'll go over the Glasgow Coma Scale, and we'll do some activities, and we'll do the slums exam and the mini mental. Other than that, you will be responsible for the rest of the content. If you have any questions, please feel free to come with questions. And if you have any questions, you can email me or come to class and let me know. Thanks for listening. Have a good day, you guys.